Hello, everybody, and welcome back. We are still talking about obstructive pulmonary conditions, and we're going to start our next case. And she's a 62-year-old female with GOLD Stage 3 Group D COPD. She's referred to physical therapy due to a 2-month history of increased dyspnea on exertion and reduced ability to perform daily activities following a 4-day hospital stay from a COPD exacerbation. And at that time, that exacerbation did not require an intubation. So you can see that there's this additional language around her diagnosis of COPD. So up to this point, we have discussed COPD as this kind of umbrella term for really two diseases, emphysema and chronic bronchitis. But when you see someone who has this diagnosis, they often have a GOLD stage, and now they're moving further and further into further dividing them into this lettered grouping. And this language is really helpful because it gives you an idea of how severe their COPD is. Because as you've appreciated from the pathophys of this disease and talking with the symptoms, there is a huge spectrum of patients who have COPD. There are some with very minor and mild symptoms. And then we get severe kind of end stage COPD, where patients are on oxygen support and possibly even nearing the end of their life due to COPD. So let's look into this tool that has been developed. It's called the GOLD's ABCD assessment tool, because in just a very short little grouping, you can really get a sense for this patient's disease. So in order to have been given the diagnosis of COPD, it is typically confirmed with spirometry, where they give the individual a bronchodilator and then do their pulmonary function test. And they look at how much air they can get out in the first second compared to how much air they can get out totally, the FEV1 to FVC ratio. And if it's less than 0.7, that's a positive finding for COPD. Beyond that, we can go further and assess the degree of airflow limitation. To get their GOLD classification, either a GOLD 1, 2, 3, or 4, it is rated based on how poor their FEV1 is, or the smaller amount of air that comes out in the first second, the worse their COPD. So a GOLD 1 is a mild case where their FEV1 is greater than or equal to 80% of what would be predicted for their age and size. GOLD 4 is the most severe, when their FEV1 is less than 30% predicted. So the higher the number of their GOLD rating, the more severe their airflow limitation. Because this is an obstructive pulmonary disease, the primary issue is difficulty getting their air out. And we went through in our previous lecture why it's challenging, whether it's mucus plugs or the reduced elastic recoil that's preventing the passive kind of pushing out of the air, as well as the collapse of the airways from that external pressure of the muscle. The more severe the disease, the more air trapping, the harder it is for them to get their air out. And that would be represented by a higher degree of their GOLD rating. So the ABCD assessment tool in those individuals who have a COPD diagnosis based on their post-bronchodilator FEV1 to FVC will get classified to the degree of their airflow limitation with their GOLD rating. But then we've added one more piece, and that's the assessment of their symptoms and the risk of an exacerbation. So they created this ABCD box to represent these two things at one time. So if we first look at the Y column, on the Y, basically, we have the exacerbation history. With every acute exacerbation to a COPD, patients kind of leap forward in the progress of this disease. Exacerbations are very, very hard on the body, and we're going to go through that in this case, exactly what happens during the exacerbation. But the more times they have had an exacerbation to COPD, especially if they had to get hospitalized, this advances the disease significantly. So if they've had 0 to no exacerbations that did not lead to a hospital admission, they can be either an A or a B. If they had 2 or more exacerbations or 1 or more hospitalizations, they will automatically be a C or D, a more severe ranking. Then they take their current symptoms, and these are representing 2 different scales that can be used to assess symptoms. Let's take a look at these scales, and then we'll come back to this slide. The first is the Modified Medical Research Council scale, or the Merck scale. And you can see that this is the number gets higher as they become more breathless with less degree of intense activity. So a 0 is they're only getting breathless with strenuous exercise, whereas a 4 is they're too breathless to leave the house. They get breathless even when dressing. So now very low level ADLs are inducing a breathless. So the higher the Merck number, the more severe the symptoms associated with their COPD. The COPD assessment tool, or the CAT, is another tool that is used. And you can see here they go through different symptoms, from coughing to how much mucus is being excreted, how their chest feels, what happens when they walk, limitations to activities at home, their confidence, how well they're sleeping, and their energy level all go into this scale to get an assessment of their symptoms associated with COPD. So if we go back to this chart, you can see if based on these symptomatic scales, their numbers are relatively low, then they can select from the far left column. So low symptoms plus almost no exacerbations, or at least no hospitalizations, that would be an A. Low symptoms, having had exacerbations, is a C. When patients are more symptomatic, more breathless, more coughing, more sputum, worse energy levels, when they're having more symptoms associated, then they can only pick from the far right column. So they have not had any hospitalizations and they've had no more than 1 exacerbation with a lot of symptoms, they would be a B. If they've had exacerbations or hospitalizations and they have more severe symptoms, that would be a D. So if we go back to our patient, our 62-year-old female, now this little extra language around her COPD diagnosis tells us quite a bit. She has GOLD stage 3, which tells you she has pretty significant airflow limitations. Her FEV1 is somewhere between 30 or 49% of what's predicted for her age and size. And group D tells you that she is going to be pretty symptomatic, and she has likely had 1 or more exacerbations that have led to hospitalization. And you can actually see that in her case, because one of the things that happened to her is that she's had 2 months of dyspnea after her most recent hospital stay due to an exacerbation. So hopefully you can appreciate that this extra language around her diagnosis gives you a lot of information in a short little period of time. So let's talk about the COPD exacerbation. So typically somebody has the underlying COPD, and then on top of that, they get maybe some kind of an infection, a viral infection or a bacterial infection, that adds additional issues to their lungs. Environmental pollutants can be a cause. But this list isn't incomplete. You can get exacerbations from heart failure because fluid backs up on the lungs. You can get exacerbations from a pulmonary embolism. Even smoking all by itself can cause an exacerbation that kind of falls under environmental pollutants. But smoking could be the only thing that really kind of tipped the scales and made things just worse enough that suddenly things in their airways got significantly worse. So remember, COPD has trouble getting air out. If you add on top of that something that worsens airway inflammation, you're going to see an exaggeration in the edema in the airways and even more mucus hypersecretion. If the airways have more mucus and more edema, you're going to get worsened airway obstruction. So they already had an airway obstruction, and now you're adding extra fluid, extra mucus to the airway. It's going to make things worse. I'm just going to pull up the picture that I used to draw out this disease. Maybe we'll add in green on the left, right? If this is the lung that they had at baseline, and now they get a common cold, they get a viral infection or they get a bacterial infection, and suddenly there's extra edema coming into this airway, shrinking the diameter further. You can see how this can significantly worsen airway obstruction because it was already narrowed from the mucus gland hypertrophy and the extra goblet cells making the mucus, the low level of inflammation that was always there, and now we've added on top of it. So we've suddenly made things much worse by further reducing the diameter. So what is that going to look like for the patient? Well, they're going to have more air trapping. This is what's referred to as dynamic hyperinflation. Dynamic hyperinflation means that when they take air in, they can open their airways on the inhalation and get air in, and then when they actively exhale, air gets trapped. So with every breath, you get more and more air trapped in the lungs, and you get more hyperinflated. If you can help to get some of this air out, you could reduce that hyperinflation. That's the dynamic nature of it. It's not a permanent state. It's dependent on the kind of the physics of the airway. They are going to get much worse dyspnea, right? They're going to have the mechanoreceptors in their lungs talking back to the brainstem and saying, that pressure changes are altered. I'm having a difficult time breathing, and that's going to give you the awareness of difficult or labored breathing. And then a cough is going to get worse. They're going to have more edema, more mucus. They're going to be coughing up additional sputum, and that will become a more obvious symptom. So this really reflects kind of the acute changes that we see simply because you're adding more fluid onto an already obstructed airway. But the COPD exacerbations are worse than that because we also see new structural damage. Their disease originated because of the inflammatory process that brought in white blood cells that used proteases to try to degrade whatever the invader was, but ultimately destroyed lung tissue, destroyed the alveolar tethers, destroyed the elastin in the lung to create these coalesced alveoli. So with every exacerbation, they get this big new round of acute inflammation, and we see more alveolar damage. And this is permanent damage. This is why with every exacerbation, they basically jump ahead in the disease progression. They fast forward the disease progression every time there's an exacerbation. With increased alveolar damage, we get decreased area for gas exchange. So with every exacerbation, their ability to get the oxygen into their blood gets worse as the alveoli gets more damaged. If we look at the symptoms that appear in response to an acute exacerbation, they should make sense based on these acute changes of increased edema and mucus hypersecretion in the airways. Dyspnea, as we discussed, cough, coughing up more sputum. This one's really key, changes in sputum color and amount. Now, I just want to take a little aside, and there's space kind of in your notes to the right where there's kind of an open white space. That would be helpful to just take some notes on what sputum color tells us. And I know this is probably the yuck part of cardiopulm, but I hope it doesn't scare you away. And it's important to talk to our patients about what they are producing with their cough because it gives you a window into what's happening in their lungs. So sputum is a gel-like substance that you can cough up from your airways. And in a healthy individual, it is appropriate. We have about 20 to 30 milliliters per day of a clear gel-like substance, like minimal quantity. You certainly don't have to memorize this number, but 20 to 30 mils is kind of typical. You can see increased amounts of a healthy, clear sputum. If you have allergies, you might see a slightly higher production of sputum, but still clear in that case. When the color changes on the sputum to either white or gray, this is a sign of an upper respiratory infection, or sinus congestion. So this is something we've all experienced when we can suddenly have kind of a whiteness to the sputum that's coming up when we cough or blow our nose. The people who have gray at this time, this is typically smokers. This is from the excessive tar and resin from the cigarette smoking. Kind of gets trapped in that mucus and gives it the gray color. When that sputum becomes thicker in consistency and dark yellow, this is a sign of an infection. So it could be viral, it could be bacterial, but now we're having a color change that gives you an idea that an infection is going on. And the reason that it's yellow, here we can even make it yellow. This is so cool. See on my whiteboard in 356, yellow doesn't show up, but it works in our virtual world. All right, so the yellow is from the fact that white blood cells are present. So you've raised white blood cells against this infection, and that changes the color to a yellow. When the sputum is green in color, this is evidence of a long-standing infection. So you can see green once the infection has turned chronic. And the green now is from the breakdown of neutrophils. So the white blood cells have been so long, they are actually getting broken down and contributing to a greenness in the color. So dark yellow is kind of an acute onset of a viral or bacterial infection. Green is something that's much more long-standing. Someone might cough up either brown or black sputum. Brown or black sputum is a sign of old blood, meaning they had a bleed at some time. Those blood cells have been in the lung and have been working their way out to be coughed out with the mucus. But this isn't an active bleed when it's that color. If they cough up something red or pink, that is new blood. That is an active bleed. And the only difference why it would be red or pink would just be less blood. So it's more diluted by the sputum or the mucus, where red would be a more significant bleed. So it's helpful to just have an idea of what the color and the change is signifying to you. Certainly if somebody was having a clear sputum and then during a therapy session it turned red, that can be a medical emergency, a sign of an active bleed. So you want to be able to respond appropriately. And we educate our patients a lot on being very aware of the changes in color of their sputum, because the earlier you can catch an acute exacerbation, the earlier you can start treatment and the less the permanent long-term changes. So in helping patients understand that as soon as they see yellow color, they should be getting in, seeing their doctor, calling their doctor, starting a treatment to try to get the infection under control so that it doesn't go chronic, can really go a long way in helping patients avoid more serious exacerbations. So if we go back to our slide, this is we just did our aside on the sputum color and amount. They can become very fatigued, they can get a runny nose. But what's important to know is there's nothing that they can test for an exacerbation. There's not like a lab test. It's not like BNP for heart failure. There's nothing circulating. There's no active cell death that's spilling intracellular things into the blood. So the diagnosis is really made based on clinical symptoms. Their symptoms have suddenly gotten worse. There's worsened hyperinflation, worsened dyspnea, worsened cough. That's how they get the diagnosis of the exacerbation. So every time that someone goes through an exacerbation, you'll see a drop in their quality of life. It will speed up the disease progression, and every exacerbation has a risk of death. That this airway obstruction can become so bad the medical team can't manage it, and they may not survive the exacerbation. So the medical team takes an exacerbation extremely seriously, and we try our best to prevent and avoid them from happening. The course of treatment, if somebody would show up with an exacerbation, is they would typically first kind of increase their dose of whatever bronchodilator they're on. So try to get more bronchodilator, a more profound response to that drug. They're going to kick in some steroids to try to knock down the inflammation, because a lot of the symptoms are just secondary to the inflammation. If this exacerbation is based on an infection, but only if it's on an infection, they would add antibiotics. And then sometimes they'll need to add additional drugs on the scene. And theophylline is a common drug that's used for exacerbations. That's probably not one that's a big enough drug to make it onto the boards, but this drug is basically, it's a bronchodilator and an anti-inflammatory all in one. So they added on kind of as an additional bronchodilator. You might see this added on in a much more severe case. So it can kind of be an indicator that someone is really having a hard time with their exacerbation. You can see on the far right here that in addition to the pharmaceuticals, many times patients will need oxygen or ventilatory support. So during the exacerbation, they may need to go on a ventilator to support the lungs when the condition of the lungs is so poor. So in addition, then they're going to address any of the comorbidities that have kind of laid the groundwork for the exacerbation, and then talk about strategies to prevent this in the future, because this is the big piece that we want to try to figure out why it happened if possible and prevent it from happening again, or at least educate our patients on getting treatment as early as possible when there's any signs of an exacerbation. Kind of a weird thing about COPD, because it's this very lung-specific disease. You know, you inhale something repeatedly, you have an inflammatory response to that inhaled thing, and that damages and changes your lung. But what we know to be true is that this is actually a systemic disease. There's whole body effects when someone has COPD. In fact, there's an elevation in their pro-inflammatory mediators with COPD generally, meaning that there's more circulating inflammatory mediators such as like interleukin and TNF alpha that cause systemic effects. And we talked about this in pathophys, that COPD is associated with peripheral muscle fatigue because of the circulating systemic inflammatory mediators. And with an exacerbation, these go way up. So when you have an exacerbation, the entire system is affected because there's an increase in whole body inflammation. So what they have found is that during an acute exacerbation, there is an increased risk of the patient having a stroke or a heart attack during and immediately after the exacerbation. So if you are treating someone with this lung disease, you want to have it on your radar that you're watching for any signs or symptoms of a cerebral vascular accident or myocardial infarction. For PTs, we have to be aware that with every exacerbation, we accelerate the loss in peripheral muscle force. The reason for this is likely threefold. They go on pretty heavy rounds of steroids, and steroids are going to break down protein, right? They are going to break down protein because basically this steroid is saying, just get enough nutrients to where we really need it, we have it. This systemic inflammation can break down muscle force as well and lead to an increase in protein breakdown. And then just the reduced activity, the same as anyone who reduces their activity, they're going to start to get weaker. So you put these three together and we see a dramatic decrease in strength, which is often what we come in and try to help reverse with PT. So it's important to remember that when you're treating someone with chronic COPD, they have issues with peripheral muscle force, but with the exacerbation, expect that to be down even further, and it'll be a focal point of your therapy. So let's go into the case now. We know Mrs. C is a 62-year-old female. She has a pretty advanced stage of COPD. Let's do our chart review. So her past medical history shows she has a history of hypertension, osteopenia, and she had left breast cancer with a mastectomy. Osteopenia should hopefully kind of make sense and ring true for somebody who has a chronic lung condition, because these patients are typically on chronic steroids. So low bone mineral density is extremely common in individuals with chronic lung disease. Her pulmonary function tests when she was discharged from her most recent exacerbation, her FEV1 was 44% of predicted, and her FEV1 to FVC ratio was 0.48. So as a reminder, less than 0.7 gives you the diagnosis of COPD, and hers is 0.48. Subjectively, she describes a difficult time walking distances due to fatigue, climbing stairs, making her bed, and carrying her 2-year-old grandchild. She has no history of falls, and she reports feeling steady on her feet. Her goals are to decrease her shortness of breath on stair climbing and have more stamina to play with her grandchild. So when you look at the tests that were done, you can see her chest x-ray shows a flattened diaphragm bilaterally. A flattened diaphragm would be evidence of hyperinflated lungs. All that air that's trapped in the lungs has pushed the diaphragm down, which is going to make the diaphragm less efficient as an inspiratory muscle. Her lung auscultation is reduced breath sounds bilaterally, and she has an expiratory wheeze. So at this point, can you answer the question, why does she have reduced breath sounds? It's the hyperinflation. It's hard to hear when there's all this air because sound doesn't travel as well through air as it does through liquid. So the more air that's trapped, the harder it's going to be to hear. And what is the expiratory wheeze from? See if you can answer that question. It's from a reduced diameter of her airway. She has a strong cough. It's dry and non-productive. That's good. That's telling us that she's not actively producing a lot of sputum, but she occasionally does have a thick, clear sputum first thing in the morning. So she is making additional sputum compared to maybe a healthy person, but the clear color tells you that it's unlikely that she's going through some kind of current infection. When you review her breathing pattern, she initiates with the upper chest. Is this an expected pattern? Very much so, because of her flattened diaphragm. You see decreased lateral costal expansion and diaphragmatic excursion. No accessory muscle use is noted. So it looks like she's not struggling to breathe, but she's using an upper chest pattern. And you see that classic prolonged expiratory phase that's seen with COPD. She has rounded shoulders with the thoracic kyphosis, but you do see hypertrophy of bilateral scalenes and upper trap. That tells you that she might not be under acute distress right now, but this long-term lung disease has caused her to use her accessory muscles more to the point where they are hypertrophied. Her strength is 5 out of 5 for bilateral upper extremities and lower extremities. She's able to perform repeated sit to stand 6 times in 30 seconds with complaints of shortness of breath, and she rates her Borg a 4 out of 10. And her Merck score is 2 at rest. So you've got some baseline functional values, baseline dyspnea values. She does her 6-minute walk test, and she gets 1,098 feet or 335 meters. So for her age, normal expected from the normative data should be around 588 meters. So she is reduced compared to normal for her age. Her RPE got up to a 5 at the end of the test. Her pulse ox was 90 at the lowest point. She was on room air though for the assessment. Her heart rate had a nice response. Blood pressure had a nice appropriate response. And her respiratory rate, again, kind of followed what you'd expect to happen during a aerobic assessment. So from your review of this patient, it appears that she would benefit from pulmonary rehabilitation. So pulmonary rehab is typically an outpatient therapy setting, and it's a really broad program that addresses many aspects of the patient's well-being. So in addition to all the medical therapy to manage the disease, pulmonary rehab focuses on exercise training. They get nutritional counseling. They're taught about their lung disease. They're taught energy conserving techniques, breathing strategies, and then there's a psychological aspect. So Medicare covers pulmonary rehab for patients with moderate to severe COPD, and it's recommended in patients throughout that scale. Our patient is a severe COPD, so she would definitely be covered in pulmonary rehab. There was a Cochrane review of pulmonary rehab programs that showed that pulmonary rehab improves quality life and functional exercise capacity more than pharmacological treatment. We know exercise works, it's been shown to work, and we can help patients by training their bodies despite the fact that they have this serious lung disease. So let's look at what we do in pulmonary rehab. A typical exercise prescription will include endurance training. The type of endurance training should be the one that the patient likes the best and that they have access to. That's the most important. So treadmill, stationary bike, upper body ergometer, you pick the thing they like, they help you find the thing they like, just make it endurance. Frequency, somewhere between 3 to 5 days a week. The intensity is listed as, moderate to vigorous. I would say your intensity should be the highest tolerated symptom limited level. See how much you can push them. Patients, they will get more out of the exercise if it's more intense. Obviously, you have to take your clinical judgment with every individual patient to know how much to push them. The pulmonary rehab guidelines say 50 to 80% of their peak work rate, or a 4 out of 6 on the Borg RPE scale. So this is meant to be RPE, not the dyspnea scale. But again, the highest tolerated symptom limited level would be the best. The goal would be 20 to 60 minutes per day for endurance training. If 20 to 60 minutes is not possible, then you should try to educate patients to intersperse exercise throughout the day to accumulate these minutes over time. Eventually, you would love to see it all at one time, a constant aerobic strain, but In the beginning, you likely will have to accumulate this time and talk to patients about how that will help and how they can slowly get longer and longer, and how that will, kind of waterfall over into other activities of their life by being able to accumulate minutes they can tolerate aerobic activity. The goal is to maintain oxygen saturation at or above 90%. Do you guys remember the significance of the 90%? That is that kind of tipping point on the oxyhemoglobin dissociation curve. When you get below 88 to 90, hemoglobin has a lower affinity for oxygen. So when patients come into pulmonary rehab, many of these patients can go through their ADLs at home without oxygen. They're just on room air at home. When they come into therapy, specifically pulmonary rehab settings have this capacity, and you really want to try to get more out of the patient, to get a higher intensity, to get a better stimulus for their exercise adaptations. It is appropriate and sometimes necessary to train with supplemental oxygen. So some patients may not need oxygen at home, but will come into pulmonary rehab, and you'll add the oxygen on in order for them to accomplish their goals. It's important to explain to patients why you're doing that. That can be scary. They don't want to be on oxygen. But if you explain that if you give their body this extra boost, they can get a better aerobic exercise out of it, which will have the systemic effects of improving their body's overall use of oxygen, you can, get them to understand how that oxygen is helping them when they exercise. And that the benefits that exercise will carry over for when they go home and they're on room air, they'll actually be able to do their ADLs even more effectively. You want to include strength training in your pulmonary rehab program. So frequency, 2 to 3 days a week, similar to a fit protocol for a healthy individual. Intensity, 60 to 70% of their 1 rep max, trying to build to a pretty high intensity, greater than or equal to 80% of their 1 rep max. So if you're doing strength, you do lower number of reps, 2 to 4 sets, 8 to 12 reps. If you're going for endurance, then you do fewer sets and longer reps. The type of strength training doesn't matter. It's what they like, they have access to, weight machines, free weights, resistive bands, you name it. Get creative, make it fun, and that will be more likely to get the strength gains in their life. Let's just take a minute to really think through why we're including strength training in our protocol. Because it's not just thrown in for good measure. There's specific benefits to strength training in someone with COPD. So the disease itself has systemic inflammation, increased reactive oxygen species, chronic hypoxia. Most of these patients are older in age, and it's very frequent that you can see poor nutrition. On top of that, the lung disease typically includes a reduced activity. It's the natural human response to difficulty breathing. If the activity is difficult to accomplish, you end up doing less. This all comes together to create skeletal muscle myopathy. This is not a healthy environment for skeletal muscle, and it gets actively broken down by the systemic inflammation, the oxidative stress, and the reduced stimulus for protein synthesis because of the low activity. So what does this look like? We're going to see skeletal muscle weakness, poor functional endurance, and a lot of fatigue. And some of the specific changes within the muscle that leads to those things, going the wrong way. Here we go. We lose blood vessels, reduced capillarization. That's the process known as rarefaction. If you are not needing that blood flow to the muscle, our body's going to take it away, and we lose capillaries. When you reduce the number of capillaries in skeletal muscle, there will be a greater distance for oxygen diffusion to any given muscle fiber. A greater distance for diffusion means it's going to take more time to deliver oxygen to every muscle fiber. Because of that, we see reduced oxidative phosphorylation, And as you're using your oxidative capacity less, you actually decrease the total number of oxidative enzymes. If your mitochondria are not running their aerobic systems at a regular rate, we do not keep proteins around that we don't need. They're metabolically expensive. Our body is going to break things down, right? If you do not use it, you lose it. So we have less blood vessels delivering less oxygen, which means we have less machines to make ATP using oxygen. And this results in a situation where you're going to start relying on anaerobic pathways to make your ATP. If you can't get the oxygen there fast enough and you don't have enough enzymes to make ATP from that oxygen, you're going to rely on anaerobic pathways, the main one being glycolysis. And if you guys remember, at the end of glycolysis, you end up with a pyruvate. And if you don't get rid of that pyruvate, it's going to shut down glycolysis. If you cannot send the pyruvate effectively into mitochondria to be used in the oxidative pathways, the pyruvate becomes lactate. Why do we care about early lactic acidosis? It increases the ventilatory requirement of the lungs. Let's just review this quickly. I'm going to go to the whiteboard. If we look at minute ventilation in relationship to exercise intensity, low to high exercise intensity, and we look at minute ventilation, that will be in liters per minute. So we got like 25, 75, 125. There we go. What happens? There's a linear relationship that as you increase exercise intensity, you increase minute ventilation, because as you increase exercise intensity, you need more oxygen. So it makes sense. As you drive your muscles more, you need more oxygen, so you breathe more, and your minute ventilation goes up. But then there is this point called the ventilatory threshold, where it no longer maintains this linear relationship. And we see an increased ventilation out of proportion to the amount of oxygen consumption. So up to this point, this ventilation has matched the O2 consumption. Ventilation kind of is equal to O2 consumption. At the ventilatory threshold, we see an increased ventilation above the capacity of our body to consume oxygen. What is this extra requirement? What are we doing here? We are asking our lungs to buffer the increase in lactic acid. So if you remember the carbonic anhydrase reaction, and I'll just write it out here on the bottom because it's my favorite. There's not many more that are cooler than this one. All right, here we go. So if we start making more hydrogen, because we're using our anaerobic pathways and developing lactic acid, which is an acid, hydrogen, it's going to drive the equation to the left, and you need to blow off that extra CO2 to buffer the hydrogen. And that's what you see here. You see a disproportionate rise in ventilation because now we're asking the lung to do two jobs: bring in more oxygen and blow off the excessive CO2 to buffer the acid. This is in a normal, healthy person. This happens naturally. When you get to high exercise intensities, you will reach a ventilatory threshold where you'll breathe more than you need to in terms of your oxygen consumption. The problem is, in COPD, patients have skeletal muscle myopathy. They have reduced capillarization. They have poor oxidative enzyme capacity, which means that at a much lower exercise intensity, they're going to reach their ventilatory threshold. We are asking the lungs of somebody who has lung disease to do more work at lower exercise intensities because the peripheral muscles aren't doing a good job of using oxygen to make ATP. This is something we can actually fix. We can't fix their lungs. We cannot make their disease get better. But this right here, this increased demand on their lungs at low levels of exercise intensity is because of changes in the peripheral muscles. And that's our business. This we can change. With therapy, we can drive them up this line so that their minute ventilation will be matched with their oxygen consumption and not necessarily being required to buffer the lactic acid. If we can get their muscles better at using oxygen to make ATP. So if we go back to this vicious cycle of COPD, you can see that the disease itself and the secondary effects on activity are what come together to create the skeletal muscle myopathy. Once the peripheral muscle gets worse at using oxygen to make ATP, we are going to accumulate lactic acid, which is going to put this excessive load on the lungs. The increased ventilatory requirement, in addition to the lactic acidosis, creates fatigue. And with fatigue and increased ventilatory requirement, patients reduce their activity further. And around you go. As your activity decreases, peripheral muscle myopathy gets worse, which means that their aerobic capacity gets worse, and around you go. You see these skeletal abnormalities in patients with COPD, but then things get even worse for these patients because typically they are treated with chronic steroids. And steroid myopathy exists all by itself. Muscle weakness is a side effect of chronic steroids. So we're adding a drug to help them control the inflammation in their lungs, but that's contributing to the peripheral muscle weakness on top of their other problems. Why do we include strength training? To interrupt and reverse this vicious cycle. It has been shown that if you improve muscle mass, you improve survival of patients with COPD. This is huge. We can make this better because we know how to target and strengthen and reverse the effects of skeletal muscle myopathy with strength training. So I included this last little bit on the very bottom of the slide. Low muscle mass is a strong predictor of mortality in COPD, and it predicts mortality independent of the degree of their lung dysfunction. These peripheral changes are huge, and we can do something about it. So that's why this patient with severe COPD would benefit from pulmonary rehab. To have this patient exercise effectively, we need to teach and encourage the use of pursed lip breathing throughout exercise. Give her the best chance to get as much air out with every breath so there's more space for a fresh breath of oxygen in to the lungs. A greater amount of volume can go in of fresh oxygen. Energy conservation techniques are huge here because the lung disease isn't going away, and we can make her be more successful by adapting her environment, changing how she does a task to break down the total energy demand, and incorporate methods that relieve symptoms like positions that reduce dyspnea will all help this patient get more done in their day. All right, some things to note about exercising patients with COPD. The first is timing of their meds. If you can talk to them about what meds they're on, if they can take a bronchodilator before they start exercise, they'll tolerate exercise better. You want to give them the best chance to handle a higher intensity exercise so you get more of an adaptive response to that exercise. So use everything you've got. Use supplemental oxygen. Use a bronchodilator if that helps them get a higher intensity. it's important to include upper extremity resistance exercise. Our upper extremity is so tied in to our thoracic cage. These muscles work together, and stronger upper extremities help reduce dyspnea and help increase the strength of the muscles that support breathing. Inspiratory muscle training may be appropriate as a way of strengthening breathing when they cannot participate in exercise fully. Right, so the best way to strengthen our inspiratory muscles is with aerobic exercise. But if they're not tolerating that to the level where they're really getting a good stimulus for strengthening, they may need some inspiratory muscle training to increase the strength of those muscles. And using supplemental oxygen whenever their saturations are equal or lower than 88% on room air. That's unacceptable. It's too dangerous of a level, and they're going to need some support. When they're going through an acute exacerbation, their body is going through a lot. So that's not the time to think about training. You might need to cut back on your exercise, do things for appropriate mobility, getting them up against gravity, but not kind of exercising at these high intensities when they are sick. So Mrs. C participated in pulmonary rehab 3 times a week for 5 weeks. At the end, she was walking 40 minutes on the treadmill. She was using interval training of 45 to 60 seconds on. She rated her shortness of breath 4 out of 10, and her RPE was a 15 out of 20 during that. She rides 20 minutes on the bike at 3 METs. She performs upper body ergometer for 10 minutes, and she's independent with strengthening and demonstrates pursed lip breathing during these exercises without cueing. When you repeat her 6-minute walk test at the end, she increased by 57 meters and she took no rest breaks. You can see the values of her pulse ox and her respiratory rate here. Her sit to stand increased to 10 times with reduced shortness of breath and leg fatigue, and her Merck score got reduced as well. She herself was able to describe an improved ability to walk and climb stairs. She had more energy to keep up with her grandchildren. She still had trouble lifting and carrying her 2-year-old grandchild, but you kind of talk through how that just might be beyond what her body can tolerate. So maybe that's not an activity that's appropriate for her to actually be carrying her, but maybe having her in her lap when she's sitting and supported, and kind of thinking about ways to have that closeness without necessarily carrying her. After discharge, she's going to go to the local YMCA to continue her exercise program 3 to 4 times a week. All right, I hope you guys enjoyed the lecture, and I'll see you next time. Bye-bye.